Good morning, everybody, and salam alaikum. Today, I will be presenting the topic of management of lower GI bleed, management of lower GI bleed as per American College of Gastroenterology guideline, which was recently, within 2 months, it was released.
Recording in progress.
So, it is a lower GI bleed is a common presentation within the hospital, and according to, and the presentation varies in different hospitals. According to a survey done in U.S. hospital, it ranges between out of 100,000 people, around 32 to 87 people present with lower GI bleed. The commonest risk factors of these patients who present with lower GI bleed is the presence of medication which include antiplatelets, including the aspirin and NSAIDs, and P2Y12 inhibitors, which include the clopidogrel and ticagrelor. They are represented with different groups of the reason of lower GI bleed is different. The more common is the diverticular bleed, followed by the ischemic colitis and hemorrhoids. But colorectal cancer, post-polyectomy bleed, colitis, ulcers, and radiation proctopathy is also one of the causes of lower GI bleed. Less common causes are Delafoy lesion, they are the vessels, and the colorectal varices. However, in usually some of the cases, although even doing the colonoscopy, we cannot identify the cause of the bleeding. According to a UK-based survey, when they identify all the patients presented with lower GI bleed and underwent colonoscopy, in 23% of the population, the source of bleeding was not identified. So, as the guidelines is based on the management, so we will be focusing on the management part of the patient presenting with lower GI bleed. So, any disease, the most important aspect is in history and physical examination. Whenever a patient is presented with the lower GI bleed, the important question we just need to ask during the history is presence and absence of comorbid diseases like cardiovascular, liver oncology, or renal comorbidities. Any history of previous GI surgeries, and what is the symptoms which led to the presentation in the emergency. Like in patient with abdominal pain, alteration, bowel habit, and unintentional weight loss may be presented as a colorectal cancer rather than a hemorrhoidal bleed. The other aspect is the physical examination. And as we know, anyone presenting with bleed, either upper GI or lower GI, vital signs are an important aspect. We need to see if there is hypovolemia, hypotension to decide regarding the resuscitation. And another aspect in lower GI bleed is that although the patient present with a lower GI bleed of fresh bleeding, we need to do a DRE to rule out whether this is malign or not, because we need to decide whether we need to do an upper GI endoscopy along with the colonoscopy or not. And the most important aspect, which we all forget, is that in the assessment in the history, medication history is very important, especially the presence of NSAIDs, antiplatelet, and anticoagulants. So, whenever a patient present to a clinic after the history and physical examination in a hospital, in an emergency, it is pertinent to triage the patient into low risk and high risk. And patients who are low risk will be less likely to have an hospital-based intervention. Hospital-based intervention means the blood transfusion, endoscopic procedure, surgical, or transarterial embolization. So any patient who has low risk on the some criteria can be discharged on an outpatient department. So for this risk assessment, there are multiple predictive score. One is the Auckland score. In this Auckland score, there are seven categories. I hope it's not which. I'll let you know what is the categories. It is age, sex, lower GI bleed, admission for lower GI bleed previously, presence of absence of blood on the digital rectal examination, the heart rate, blood pressure, and hemoglobin. On the basis of this score, if the score is equal or less than 8, then the patient is considered to have a minor bleed and can be discharged without any intervention and can be followed up in the OPD. There is another, sorry, this is the same slide. And the other one is the shape score, which is as the name says, S is for systolic blood pressure, H for the hemoglobin, A for antiplatelet anticoagulant, pulse more than 100, and presentation in the emergency department with bleeding. If the score is equal or less than 1, then this indicates that the patient is less likely to have an hospital-based intervention. As I already explained, what is the hospital-based intervention? It is the patient who required blood transfusion, requiring endoscopic hemostasis or arterial embolization or surgery. But however, these risk predicting scores are promising results, but they are not widely accepted and they are not recommended at the moment to do the assessment of on these score basis. So the most important aspect in patient who could categorize whether they are a low risk and whether we need to do procedure now or later is dependent upon the clinical acumen of the clinician who is attending the patient. So coming to the management part, whenever patient present with lower GI bleed, what we will need to do is to resuscitate with the patient. This is a part of the flow chart the guideline has recommended. So I've cropped it up for the to go step by step. So any patient who has presented with severe hematochezia, we need to do a fluid resuscitation in the form of collide and to manage his pulse rate and heart and the blood pressure. Sorry. In cases of severe bleeding, blood transfusion is required. So the American College of Gastroenterology has recommended for a restrictive transfusion, meaning that the hemoglobin above 7 is enough. We don't need to go up in cases of GI bleed to go above. However, if there is the patient have acute coronary syndrome and presenting with GI bleed, we can cut off of 8 gram per deciliter. The reason being of going for restrictive blood transfusion is that it has not giving more blood has not shown any mortality or outcome benefit in these patients. But the important aspect we need to rule out is the source of upper GI bleed. And we need to decide whether we need to do the upper GI endoscopy in this patient. The patient who have higher predictors of having upper GI bleed will be having an history of peptic ulcer disease, portal hypertension with bun and creatinine ratio more than 30, taking aspirin or NSAIDs, and presence of positive NG lavage. Although this NG lavage is not recommended, but if it's done and there is bleeding in that, we need to go for an upper GI endoscopy in these patients. So after the resuscitation, if the patient is on coagulopathy, as I said, this is the most common risk factor for lower GI bleeds, and patient is on anticoagulants or antiplatelet. What is the management plan we need to do? So any patient who are lower GI bleed, we need to see the coagulation profile. And the guideline says that endoscopic hemolysis can be considered safe and effective in patients who have INR of 2 or of less, 2.5 or less. So we can perform the without correcting the coagulation. But it depends what is the presentation of the patient. If the patient presenting with severe bleeding and there is hemodynamically instability and the INR is prolonged, then we need to use the reversal agent. But if the INR is prolonged and we're not planning for any intervention, we can continue the anticoagulants. Coming to the anticoagulant one by one, one is the vitamin K antagonist, the warfarin we use. So the guideline recommends that if there is a minor bleed and we're not planning for intervention, we can continue the anticoagulant. While there is significant bleeding happen, we can hold it for a while and do a procedure, and when patient stabilize, we can restart. But if there is hemodynamic instability and there's severe bleeding is going on, we need to reverse the anticoagulation in the form of vitamin K, fresh frozen plasma, or 4-factor or thrombin complex concentrate. On the basis of the European and American guideline, both prefer prothrombin complex concentrate as compared to FFP because it has a rapid reversible of INR, and there is less risk of volume overload if we give FFP. Although European prefers to give vitamin K with PCC, while the American guideline do not recommend the uses of vitamin K, only prefer PCC if they are available. Otherwise, we have to go for the FFP. In case of direct oral anticoagulants, which are commonly used nowadays, the criteria is same. In case of minor bleed, we will continue. In case of significant bleed, we will hold. And in case of life-threatening bleed and the patient has not responded to the resuscitation and stopping of the drug, then we need to target reversal of anticoagulants. So this is a summary slide in which I will be calling the targeted reversal. In case of direct oral anticoagulant like dabigatran, the reversal agent is idracizumab, while in case of rivaroxaban or epizaban, the agent is andexanet. We need to consider that these agent has given within 24 hours, then these reversal agent will be affected. Plus, we need to these reversal agents are mostly not used because most of the patients are managed with blood transfusion and stopping the drug only. So, in case if the patient present with any of this, which we need to keep in view of these reversal agents. So, according to the antiplatelet, the aspirin, there is no as such data regarding the management of antiplatelet in this, but we do not need to transfuse empirically the platelet if the patient is presenting with bleed. But if there is a significant bleed happening, we need to maintain the level around more than 30 into 10 to raise power 9 per liter. And we can consider more than 50 if we are going for any invasive procedure, whether endoscopically or CT guided. So regarding the aspirin, if it is the patient presented with a bleed and it was used for primary prophylaxis, we need to stop, permanently discontinue the aspirin in these patients. While if it's in for the secondary cause and the patient is presenting with severe ongoing bleed, we need to temporarily discontinue, but in the with the consultation with the multidisciplinary approach for considering what is the risk factor for the cardiovascular and thrombosis. While patient is on dual antiplatelet, the aspirin can be continued, but V2Y2 receptor has to be hold like the clopidogrel, and it has to be resumed within 5 days, because if it has to resume in 5 days in patient who have an history of stent within a year. In the last year, if there is a stent placement, we need to resume early as possible the P2Y2 inhibitors, because there is very high risk of stent thrombosis. But the multidisciplinary approach is also required in this case. There is no recommendation of using of antifibrinolytic agent, which is a tranexamic acid in lower GI bleed, moreover even in the upper GI bleed. So whenever the patient presented to us, we did the hemodynamically instability, and we have considered what is the coagulation profile of the patient. Now we need to identify how we will diagnose what is the cause of the lower GI bleed. So there are three diagnostic testing: CT angiography, colonoscopy, and RBC scintigraphy. So coming back to the chart, as I said that after resuscitation, if there is an ongoing significant bleed, here the guideline is actually changed as compared to previously. That if there is ongoing significant bleed, the American College of Gastroenterology prefers to go for CT angiography. Reason being that it is rapid, it does not require a colonoscopy preparation, and it is dependent if the facility is available within the hospital. Although the guidelines says if the expertise is more on the colonoscopy and the expert can manage the ongoing significant bleed in the presence of colonoscopy, we can go for the colonoscopy, but they prefer CT angiography. And the predictors of positive angiography include if the CT angiography is performed within 4 hours, there is a bowel history of any surgery, bowel resection or intervention. If there is more than 3 blood has been transfused, the patient is on antiplatelet or direct or oral anticoagulants, tachycardia and hypotension. And the same say that if there is no interventional radiology present, then we can go for prompt colonoscopy after resuscitation. So on if the we will go this part first. The CT angiography, if showing any extravasation, we can go for transcatheter angiography depending if the facility is available. Otherwise, we can go for urgent colonoscopy. Urgent colonoscopy means and rapid preparation in the form of high volume polyethylene glycol preparation or given over the 3 to 4 hours, and it can be performed as a first line if the CT angiography is not available. Now coming to the second part, that if the bleeding is lower GA bleed and the bleeding has subsided, we can go for non-urgent colonoscopy. This is what the difference is between the previous guideline and now, that we do not have to go for an unprepared and bleeding patient to do colonoscopy within 24 hours. We can wait, prepare the patient and do for colonoscopy after 24 hours with split dose polyethylene glycol. The reason being, if whenever the colonoscopy is prepared, we will be able to see the whole mucosa on the entire area. We will be able to wash the stool and the blood through the water jet. And an important thing we need to do, which we already do, that we intubate the ileum to rule out there is any source of bleeding from coming from the small bowel. And they recommend the use of clear cap for the detection of and the treatment of the bleeding. Uh, and they prefer that if the patient is hospitalized for the liver GI bleed and even the bleeding has subsided, we should go for the colonoscopy. But there are some patients in which we can avoid the colonoscopy. One is the patient in which the bleeding has subsided and the colonoscopy has been done within 12 months with adequate preparation, and they have diverticulitis, but the colorectal carcinoma has been excluded. So we can avoid these patients with the repeat colonoscopy. The other patients are those who have, we know that they have a divertical bleed in the recent lower, in the recent colonoscopy, and we know that this is the same bleeding, and this is the patient is stable, so we do not need to repeat the colonoscopy in this patient. But we need to also consider, although if the within the past 12 months, if the colonoscopy has been performed, there is no cancer, and there is only diverticulitis, but the patient has a new onset of symptoms, then we need to do the colonoscopy to rule out other causes like ischemic colitis or IBD. So the decision to do the colonoscopy depend on the situation of the patient. The third diagnostic is the nuclear imaging 99 technetium label RBC scintigraphy, which is not used nowadays because it's a longer study. It will not give you a precise location of the bleeding. And it is only used in some circumstances where the CT angiography is not available, or there is high risk of contrast-induced enteropathy. Otherwise, the colonoscopy does the thing, so it is really used nowadays. So, as I previously said, that they have now recommended that we need to do the non-emergent inpatient colonoscopy uh, after 24 hours, because they have, when the head-to-head trial were done in multiple studies, they have not shown any benefit in the clinical outcome like rebleeding and mortality. This is a summary of a meta-analysis. If we focus on the 4 randomized control time of this multi-analysis, we can see that there was no non-significant difference between the groups who had an urgent colonoscopy less than 24 hours or elective more than 24 hours in diagnostic yield, rebleeding, length of stay, blood transfusion, endoscopic intervention, and mortality. But if we added the observational studies in this data, the urgent endoscopy have shown some benefit. But considering the result of the randomized control trial, the American College of Gastroenterology recommend for the elective colonoscopy as compared to urgent colonoscopy in patients who have stable lower GI bleed. But they say that the urgent colonoscopy can be performed in cases when we have very high probability that we will find the cause of the bleed. Like we have done a polypectomy, and within 1 or 2 days the patient represent, we know that they may be the polypectomy bleed has happening, so we can go urgently. But has to be performed by the expert. The assistance of the clear cup and water jet should be used, and but however, they are still focusing that we should consider for CT angiography if the facility is available and there is very significant bleed going on. The preparation is, as said, that previously it was like large volume 4 to 6 liter of PEG based bowel preparation. Now they are focusing on the split dose or low volume, which we regularly use in our patient for PEG preparation. They do not recommend endoscopy in patients who are unprepared or for only for sigmoidoscopy. Unless the reason we know that there is only the endorectal area or distal colon is the bleeding site. Otherwise, we need to prepare and see the complete colon for the source of the bleed. So whenever we do an endoscopy, we have we usually do the endoscopic therapy, and there are multiple treatment options available depending on the what is the cause of the bleed. So the options are epinephrine, clips, band ligation, thermal therapies like including the APCs, and hemostatic sprays. So coming one to one with the source of the bleed, if the patient present with diverticular hemorrhage, they usually present with large volume painless hematochezia because it is an arterial bleed. And in cases when there is an active bleed like spurting or oozing happening, or there is a visible vessel or an overlying clot is there, then and it's not removed with the washing, then we need to do the intervention. So the preferred method is the clipping. There are two methods of doing. Either we directly clip, this is the vessel and which is oozing, and they have directly placed the clip over the vessel. Or otherwise, there is another method that we approximate the walls of the diverticulum, and this is called a zipper manner. But this is not preferred because of the there is another chance of rebleeding in this. So direct clipping is preferred. The other method is band ligation. In this picture, you can see there is a pooling of blood within the sigmoid colon. This is the diverticulum. They have tattooed the area with the methylene blue. And then this is the cap, this rim. This is the cap. They have suctioned the diverticulum inside and they place a band. The band actually slides over the cap and it's ligate and it becomes like a polyp, you can say, if you don't know what I mean, that becomes a polyp, and then this area is ligated. So the vessel ligate and then it shed off. So this is also a management of band ligation in cases of diverticular hemorrhage. The second cause of the bleed, which is commonly seen, is colonic angiectasias and vascular etiologies. These patients usually have a slow occult bleeding and they present with iron deficiency anemia. The common people who present with this are advanced age and patients who are on anticoagulants. The preferred method for this patient coagulation is argon plasma coagulation. It is a thermal coagulation and it is very effective. And in cases, if it is in the right colon has a very thick mucosal wall. So it is thin, sorry, thin, sorry. Thin mucosal wall. So there is very high risk of perforation if we do the coagulation directly. So we prefer to go for a submucosal injection to raise the mucosa and then do the APC. And clipping can also be performed in these patients if they are refractory to the coagulation. The third, which is most commonly seen, is the post polypectomy. It's the more common. And the risk factors of patient who have polypectomy bleed is the patient who are on anticoagulant, have a left-sided polyp. We have used electrocautery for the polypectomy and making the mucosal wall thin, and a pedunculated polyp morphology. However, whatever the polyp we've removed, in the 43% of the cases, there is no post polypectomy bleed is happening in these patients. But when there is risk factor, we need to consider and keep a close eye on these patients. So the management on these patients who after polypectomy bleed is the clips, thermal coagulations, and the hemostatic spray. This is a summary slide of whatever I just say. It depend, as I said, depending upon the cause of the bleed, the management depends. Like in cases of diverticular hemorrhage, uh, clips are the preferred method, and the direct clipping is preferred rather than the indirect clipping, which I saw the zipper method. Then we can go for the band ligation and coagulation also. And coagulation is preferred if the neck of the diverticulum is the site of the bleed. Other options is include the hemostasis spray, heparin, over the scope clips, endoscopic snare ligation, and Doppler probe guided therapy. For angiectasia, we have argon plasma coagulation. Other options include clips, epinephrine, submucosa, the same to increase the, which is preferred in the right colon, to raise the submucosa and then perform the coagulation. And in cases of polypectomy bleed, clips are the more preferred method and very effective. And include other options include direct thermal therapies, argon plasma coagulation, over the scope clips, topical hemostasis spray. So after identify the location either by the CT angiography or by the colonoscopy, there is high chances the patient will present with recurrent bleed. So in case of the recurrent bleed, there are some risk factors which these patients will more likely to present with the recurrent bleed after the hemostasis, which include the older age, hemodynamically is stable at the time of presentation, and patient presenting with diverticular bleed. So then we need to decide whether we need to do the colonoscopy, angiography, and surgery for them. So it is preferred that although there is limited comparative data in any patient who present with GI bleed, recurrent GI bleed, and we need to go for CT angiography or colonoscopy. The pathway which American College of Gastroenterology recommend that if the source is of the bleeding is treated endoscopically, and it has, we know that this is the reason of rebleed and we can treat it endoscopically, then the repeat colonoscopy is considered. However, we know the site of the bleeding and there is recurrent bleed, we know that we went in and we did the all the best possible option, and we went again if there was a recurrent bleed. Now this is a refractive bleed, then we can go for transcatheter angiography for possible embolization. In cases in endoscopic intervention was performed before, the clip we have placed usually is become the source of the focal point for the angiography. So it will help the interventional radiologist, if the facility is available, to target that area for angiography and perform the embolization. Surgery is not the indication for a primary GI bleed, and it should be only considered when endoscopy and radiological intervention have failed, which we usually follow. And it has a role if the recurrent significant bleed after initial arterography and embolization is there, we can go for the surgery. Either we have failed to treat colonoscopically, or the patient is not a candidate for repeat colonoscopy, or the recurrent embolization cannot be done because of the ischemic colitis, then we can go for surgical intervention in these patients. So after stopping, and if there is no recurrent bleed, what to do with the antiplatelet medication and anticoagulant which we have stopped. So in cases, because the largest data of these agents are present in the diverticular hemorrhage, they have only focused on the management of these patients. So patient who have on NSAIDs, everybody knows anyone patient with NSAID and present with upper GI bleed with ulcer or ectasia, we need to permanently discontinue this NSAID, and we do not need to restart after when the hemorrhage has stopped. In cases if it is used for aspirin, as said before, it has to be permanently discontinued because there will be high risk of recurrent bleed in these patients. If the aspirin is used for secondary prophylaxis, it can be continued, but the patient has to be informed, and we need to keep an eye on the patient. There is another there is a risk of bleeding, but we need to continue the aspirin because there is an increased risk of to avoid the future ischemic events. For P2Y2 inhibitors, the clopidogrel, we need to sit with the multidisciplinary team to discuss the risk and benefit of continuing these agents, because there is a high risk of recurrent bleed in patient, but we need to keep in the why the thrombotic and cardiovascular risk factor of the patient, and we have to decide accordingly. Regarding the anticoagulation, we need to continue after the hemorrhage has stopped. There is no bleeding. We can restart the anticoagulation because we need to decrease the thromboembolism and mortality in these patients. And it is preferred to resume these anticoagulant within 7 days of the bleeding event whenever you stop, because to avoid the thrombosis. Thank you.